Good morning, everyone. I'm Ayush Arora of the Cardiology Fellows here at UT McGowan Medical School, and I'm going to discuss an interesting case of right ventricular failure in acute myocarditis and discuss the support strategy, whether to do it upfront or as a bailout strategy. I have no disclosures. So our patient is a 48-year-old man with history of hypertension, obstructive sleep apnea, morbid obesity of BMI of 44, who presented to an outside facility with chest pain, shortness of breath, peripheral edema, palpitations, and elevated troponin. EKG showed diffuse ST depression in lateral precordial leads and some isolated PVCs. Vital signs: at that time, patient was afebrile and only significant for O2 sat of 96% on 30% FiO2. Coronary angiogram done at the facility showed non-obstructive coronary artery disease. However, he had sustained ventricular tachycardia, which was managed with dual antiarrhythmic therapy and cardioversion. Around day 5, patient progressed to shock with multi-organ failure with lactic acid elevation, and the patient was then subsequently transferred to our hospital. This is the echo at the time of presentation to our hospital, which basically is showing dilated LV with severely compromised LV function to 25% or so. This is a two-chamber view. Patient was taken to our cath lab straight up, and hemodynamics were performed, which showed a RA pressure of 26 millimeter of mercury with a wedge of 29. He was saturating 100%. He was on 100% non-rebreather mask, and his PSATs were 31.9% with a cardiac index of 1.16. ABG at that time showed PO2 of 73 on 100% O2. At this time, we were thinking about different support strategies, whether to just manage medically with vasopressors and inotropes versus balloon pump, Impella, tandem heart, Bailout, or VA ECMO. And given the acuity of presentation and ongoing hypoxia, we went ahead with Impella CP. And within 5 minutes, we noticed improvement in hemodynamics from PSAT going from 31% to 49%, and cardiac index from 1.16 to 1.5. However, patient's hospital course was complicated with recurrent ventricular tachycardia, which required cardioversion, respiratory failure requiring mechanical ventilation, and renal failure requiring renal replacement therapy. At that time, we performed hemodynamic monitoring again, which showed persistently elevated right atrial pressure to 16 millimeters of mercury, which is improved than before, but still not optimal, wedge of 16, and index of 2.06. The endomyocardial biopsy done at the first right heart cath showed lymphohistiocytic myocarditis, for which we initiated treatment with steroids and IVIG. This is the biopsy, which is showing lymphohistiocytic interstitial inflammation with evidence of myocardial cells. However, no giant cells were seen on the initial pathology. Given suboptimal response to Impella CP and expected prolonged hospital course, we decided that we should upgrade the Impella to 5.0 with a subclavian approach. However, intraoperatively, patient had high-grade AV block and asystolic arrest, and right femoral VA ECMO was placed in the OR. Subsequently, the hospital course was complicated with peripheral vascular injury, subarachnoid hemorrhage, and right lower extremity DVT. And we were able to decannulate VA ECMO by day 19 of the hospital stay. Patients still continued to have ventricular tachycardia despite dual antiarrhythmics and multiple cardioversions. And VT ablation was entertained and performed successfully on day 35. At this time, this is the apical four-chamber view, is the Impella showing in the LV cavity. The LV function seems to have improved compared to the initial presentation, where the LVEF estimated to be around 35 to 40%. This is the two-chamber view demonstrating the same. At this time, we had weaned off Impella from P7 to P2, and we performed another set of right heart hemodynamics, which showed right atrial pressure of 7 and wedge of 20 with a FIC cardiac index of 1.95. At this time, the right axillary Impella 5.0 was decannulated on day 44. However, patient had decompensation after that and had recurrent ventricular tachycardia, went into pulmonary edema and respiratory failure, and was emergently taken to cath lab with an intra-aortic balloon pump insertion. Hemodynamics were performed at this time, which showed right atrial pressure to 14 and the wedge of 19. PSAT was 38.6, and the index was 1.76 on balloon pump 1:1 and milrinone going at 0.25 mics per kg per minute. At this time, we were deciding upon what's the long-term strategy to support this heart, whether he's a candidate for heart transplant or total heart, artificial heart, or to do LVAD with possible RVAD centrimag. We placed hardware off pump with apical placement. Within 12 hours of hardware placement, patient had hypotension and low flow on LVAD and higher pressure requirements, and subsequently RV failure, and VECMO was cannulated at bedside again. Patient was taken to the OR where RVAD centrimag was placed and ECMO was decannulated, and core biopsy at this time showed fulminant giant cell myocarditis, which is different from our initial pathology of lymphohistiocytic myocarditis, and then we initiated treatment with cyclosporin and plasma exchange. This is a slide demonstrating the giant cell myocarditis. The first slide is the low magnification, which is showing group interstitial inflammatory response. However, on the higher mag, you can see the red arrows pointing towards the giant cells, which was not seen on the earlier biopsy, which was done on endomyocardial biopsy. So learning points from this case are understanding biventricular failure and treatment strategies for LV and RV support in acute and subacute settings. LVAD with rescue RVAD versus upfront RVAD was the question that came up. And the sampling error, as you could see, the first pathology was an endomyocardial biopsy, which showed lymphohistiocytic, and the second one was core biopsy, which showed giant cell myocarditis. And there's more discussion about how to de-escalate the mechanical circulatory support, as in this case, we de-escalated from Impella and weaned off based on hemodynamics, and the patient subsequently had LV failure. After VAD, we noticed RV failure. So a lot of discussion points about weaning off.
Thank you, Ayush. Wow, that was some case. I'm sure it'll generate some discussion. And for the panelists?
Excellent case. That was a great case. A couple of questions. I mean, obviously, these are hindsight's always 20/20, and we learn a lot in taking care of these patients. But looking at this patient, in terms of how they presented and how they really evolved dynamically during the course of the hospitalization, what do you think about perhaps an upfront approach of putting them on either 5.0 with an ECMO, see how they do, and then assess their clinical course? And the other question is, given this patient's dynamic status, what do you use in your hospital in terms of your ECMO weaning strategy aside from a ramp down? Do you look at echo, like global longitudinal strain? When you do the cardiac outputs, do you do mostly thermos? And also in these patients that are coming in like this, do you look at the pulse pressure, the amount of pressure requirements? Every institution has different ECMO weaning strategies. I'm curious to see how you do it at yours.
In this particular patient, I know we had initially difficulty weaning him off of ECMO, and we did not have good pulsatility, but around day 20, we had good pulsatility with ECMO and improved hemodynamics. I think that was the way we were weaning off of ECMO in the first place. And as far as going up front with more advanced mechanical support, when we had Impella CP, it was done under emergent circumstances when the patient was really hypoxic, on 100% non-rebreather mask. And that time, that was the strategy that was chosen.
A great case. He got everything we know, right? So I have two questions for you. How many biopsies are you actually taking? We are taking 4 to at least account for the sampling error. And before you put them on the LVAD, did you try to do something with him? So what's your policy there? Do you try to really decongest them? Because that might have altered the course a little bit, while I'm not sure that what you have done. So
we do take four biopsy specimens at least on all myocardial biopsies. And in terms of before going to VAD, what else we could have done is to maybe consider that RV might not be as much forgiving as we thought it might be in this case. Literature has shown that if you do RV support up front, you may have better outcomes compared to a bailout strategy. Yet we also think in a lot of cases, RV would be forgiving in a biventricular failure scenario. So it's a very reasonable thought to consider RV support up front.
I have a question for Dirk. I've heard you guys do a lot of LV biopsies. That's not usually, in US, we don't do as much. What is your experience with LV biopsy?
Yeah, we have a study published a couple of years ago with this very similar safety profile. And for us, it's an LV disease mostly. Therefore, I don't find the RV stuff so obvious to take RV biopsies. So, and then you always say, okay, I try to go septal to mimic the LV, but I think that's very, very difficult. And I mean, doing that and use a EBO guiding catheter, that's pretty easy to do, and actually our fellows do it. Very similar to right heart catheters. So, and they like to do it because they are very easy to start with coronary angiograms anyway then. So
all the 4 biopsies which you took routinely is from LV?
Yeah, only LV anymore. The only thing is follow-up biopsies after heart transplantation. That's right heart, but that's another disease.
Yeah. Thank you. Any questions? Yes, Ramesh, I'm sure you had a question.
Just one point, and I want to hear people who put in routinely fellas. When you have a big right bundle, your conduction is really going through the left bundle, so I'm not surprised you had, AV block when you're putting a big catheter across and just impinging upon the left bundle and left posterior fascicle. I just wanted to see if there was, is this something common? Because this is something, as an EP, I worry about. When you have a right bundle, left anterior fascicular block, simply plopping across a pigtail catheter will give you a complete AV block. In a patient that sick, it can be the difference between survival.
That's a very good point. The standard teaching in fellowship is when you're doing a Swan-Ganz catheter and the patient has a big left bundle, be very careful putting a Swan, because you bump the right bundle and next thing you know is asystolic, have a pacemaker in the room. But we don't pay as much attention for big left bundles who are crashing and putting impel as I think we should. This case definitely demonstrated that probably the last his Purkinje fiber, which was conducting, was knocked out by the impella, and next thing you know is patient's coding. Absolutely, that's a very good point.
One point, a follow-up to that is, in this case, the suspicion for giant cell was raised big time when that complete heart block came up. Because just something, I mean, even though you're right about that, we still get away with so much. We shouldn't. We should think about safety. I got burned once with a right heart cath and biopsy with a patient like that. But I'll tell you, I think I think in this case, I want to ask not just you again on the EP side, but our colleagues here. When you have this suspicion for giant cell, which may have started with the presentation of ET. I mean, this guy was a giant cell without a basis, right? He had no autoimmune disease. He's like a singleton giant cell that's presented. So one, look how we got fooled a little bit here. People say giant cell doesn't recover. It does recover sometimes. Maybe heart rest sometimes helps. I've got at least 2 or 3 patients that are, thank God, stable on very aggressive anti-lymphoid treatment, and they were just slow giant cells. I biopsied them because of their risk profile. One of them had a thymoma, and the other one had some kind of autoimmune disease. But I wouldn't have biopsied them aggressively. And towards the LV comment, just one thing, we do have a protocol now shared between Mayo and Penn. It's a great protocol, and I hope we'll learn something from it, where you're doing LV biopsies under the EP mapping, under the mapping of the ventricle. And the idea is, the question for this study is they're randomizing patients to basically doing, just RV versus mapping RV and LV and figuring out.
I think it's a great idea. It will decrease your sampling errors. It's actually very straightforward to do.
Yeah, they are trying either with the electric mapping or MRI. But again, when I'm adding all these things, I'm adding in my head, when this family gets the bill for everything that we have thrown at this patient, probably we single-handedly has destroyed Medicare.
One observation about.
Do the MRI.
Yeah.
So I
One up-
wanted to know from
so I think the
Columbia
patient-
and Dr. Feldman, how aggressive and where do you stop? Is there any protocol that you have where you say, you know what, we're not going to go any forward?
So science is science, and we need to move that forward, but we pay for that. You should never do a test if, in fact, you don't know what the results will yield you an answer that's going to change patient care. I have that discussion with our teams all the time. One of the things I would say about this giant cell case is that, in fact, we recently had a case similar to this where we had a woman who had a giant cell and profoundly started to decompensate quickly, wound up getting a VAD. Didn't actually recognize at the time that she had a significant degree of RV dysfunction, but it really wasn't that bad. Over the course of probably 9 months to a year, she actually had significant recovery of her LV function while her disease continued to progress on immunosuppressive therapy. By the way, she had a giant cell, she had a renal cell carcinoma as well, so that made things a little more complicated. So In a patient with a VAD with giant cell, we actually did a nephrectomy. She's one of those people who said, I want everything. I'm hoping for a miracle. And we kept saying, oh, okay. And the interesting thing about this particular case was it was a case where, in fact, the patient served as their own control, where you could see how typically unsuccessful we are. Granted, the RV and the LV are not the same, but the RV continued to deteriorate. She's listed for transplant now, and now has recovered LV function. And then the question became, should you take the VAD out? We've decided to keep it in because we thought that, in fact, we'd already won against the house in Vegas too many times, and we would lose next time. But I stop when, in fact, we don't have a responsibility to offer therapies to people that aren't going to yield benefit to them. We're not made of silicon, so the idea of replacing a portion of the heart with silicon is not going to work, and we shouldn't offer therapies just because, in fact, we're interested, unless it's part of a scientific protocol.
David, just as a follow-up for our colleague here who presented, what do you think you should do next? Because to his point, we have giant cell patients who get, our protocol calls for BIVAD, so we've done 2 hardware BIVADs. We had one that was a Thortec BIVAD, all came to transplant well, but not with great survival post-transplant, all of them, just to be clear. But what would you do next? I'm curious, especially if she starts showing signs of RV failure on permanent LVAD support.
So currently, our patient is still in our ICU. He has the LVAD and he has the RV CentriMag, and we're trying to wean off of RV CentriMag and still making a long-term plan whether he would be a candidate for a total artificial heart or a heart transplant. Or if his RV recovers, then that's a different case.
And did you treat the giant cells after?
We treated with cyclosporin and plasma exchange.
But no VAD.
So to Dr. Carr's point, when the way you just phrased that, sir, is you said, we're still deciding. I mean, if the patient's not going to live and you're not going to transplant them and you're not going to take another step, then I would maximize immunotherapy, and everybody would rather die at home or on a beach in Mexico than in the hospital bed in the CCU. So that palliative care talk we had yesterday was absolutely fantastic. And so, determining expectations probably for the medical team is about what y'all are willing to offer, and what the patient's expectations are probably are very important. I mean, if they think they're getting to a heart transplant, and to Dr. Rami's point, if we know that they have a markedly attenuated, typically, post-transplant course, do they want to go through all of that to potentially live, I'm going to make up the number, 2 more years?
Let me make it a little more complicated, as if it was not complicated enough without violating HIPAA. This patient is neurologically completely intact, very young guy. And the family obviously went through hell. And finally, the love of his life decided to get married on biventricular support in the ICU. Now go figure, you're going to get palliative care to see what is, like he said, the 2-3 questions. One of the questions is, what is the goal in your life? A guy just married day before in the ICU. What do you think his goal in life is?
I'd have to start off by asking him what his motivation was for getting married then. I think sometimes people do that as a symbolic gesture. I couldn't even begin to get in somebody's head who had BIVADs and myocarditis and decides to get married. But
how do you bring up that conversation? This wedding was symbolic, or this wedding was really human?
I wouldn't make any assumptions about, I'm only responsible for me. But, say, I don't know, maybe there should have been a discussion beforehand. That's not really fair for me to say, about this is your lifespan. Mm-hmm. If, you said, I think you realistically have, because of arrhythmogenesis or the deterioration of your ventricle, even with a heart transplant, you're likely to have between 6 months and 2 years. You've probably already eclipsed the 8 months that we would predict for a patient like this that would have a profound mortality. If y'all are willing to go forward with this marriage, of course, we wouldn't stop you when we endorse that. However, or you never say but or but, yes. However, you say yes, and now what would you like to otherwise us help you with the rest of your life plan? You can start your bucket list tomorrow. I mean, if that was the case, and I found the woman of my dreams, and I knew I had a year and a half, I'd be in a big hurry to get out of the hospital. Spend some time with them before I die.
David,
I wouldn't call it a dream. I'll call it a nightmare.
David, every patient's different. I'll tell you, a South Philly family got married in our ICU, and when our social worker asked, why'd you get married in the ICU at this point? You know, trying to get that bigger question, she said, we couldn't book the chapel down the hall. And that was it. There was no other answer. And the story. People are people, I think.
Well, Ayush, thank you very much. That was a very interesting case, raised a lot of questions.